When it comes to addressing heart conditions among young patients, medical advancement has been truly remarkable. Non-surgical and less invasive approach are used to minimize risks and recovery time. My name is Beldin Waleula, and on this week's episode of Health Watch, we'll be talking to leading experts in pediatric cardiology who are skilled to treat heart defects.
While most children are born fit as a fiddle, some come with congenital conditions. These include heart defects that need different interventions immediately after birth or later in life.
When I talk of children's heart conditions, there are basically two. The one that you are born with means it is congenital, it is present at birth. And then the one that you acquire as you grow. The ones that you acquire as you grow, there are some which are post-infectious, like rheumatic fever and rheumatic heart disease, which is from an untreated sore throat, is still common within our setup. And then we now have other diseases coming in, the children who are basically quite heavy, obese. If you start being heavyweight when you are young, then a lot of things also will stress onto your heart. And so those, and also the lack of physical activity.
There are different types of congenital heart conditions that babies can be born with. One such is atrial septal defect, or ASD. ASD basically is a hole in the heart that is between two upper chambers in the middle of the left and the right atrium. Another condition is ventricular septal defect, which is a hole between the lower chambers of the heart that is between the right and the left ventricles. These conditions can be treated through an open heart surgery. However, a minimally invasive surgery where a catheter is used to place the closure device in the hole works perfectly. Today, we will take part in treating an atrial septal defect, which, as indicated earlier, is an abnormal opening in the wall or septum between the heart's two upper chambers, and also known as atria. Look, every baby is born with a small opening there. The hole usually closes a few weeks or months after birth. But some babies are born with larger holes that don't fully close naturally. The closure procedure is performed by a heart surgeon or interventional cardiologist, both who are specialists in heart procedures.
You know, heart has got four chambers. The two upper chambers are called atria. The two lower chambers are called ventricles. The right atrium receives the deoxygenated blood from the body. The left atrium receives the oxygenated good blood from the lungs. If there is a hole between the two upper chambers, the blood goes from the left atrium into the right atrium, leading to enlargement of the right-sided chambers. This leads to weakening of the right side of the heart, increase in the pressure on the right side of the heart called pulmonary hypertension. So it needs to be closed.
Before the surgery, the young patient is prepared for the procedure. These usually follow several medical tests done beforehand. First, they knock them out using gas, and some through intravenous injections. Once they fall asleep, they are connected to machines that will be monitoring their vitals. Kids wake up from anesthesia quite sooner than adults. So just to avoid any movement that may interfere with the procedure, their legs have to be still. Then a cover is put over them to protect them from radiation exposure from the imaging machines. A blood vessel is identified in the groin area. A small incision is made. A catheter, which in layman's language means a small tube, is then inserted through this small opening that has been made, and it goes all the way to the heart. At this time, the team available is closely monitoring the baby. Sometimes the echo machine is used to have a better insight. Professor Christine Joey is a pediatric cardiologist. She has been spearheading the Matter Heart program since 1994. She takes us through what will necessitate a child to undergo a heart procedure.
In pediatric cardiology, it also has a lot of branches, and one of the branches is intervening. Once you've made a diagnosis, instead of sending them for surgery, you can also intervene. So also that branch, this branch is called pediatric interventional cardiology. And within the country, we do it in Kenyatta National Hospital, at the Mater Hospital, and a few other places now that the cath lab is there.
There's a team of nurses, anesthesiologists and pediatric cardiologists offering support to the main surgeon by ensuring every piece of equipment and tool is available. Then the procedure will start.
So this is going to be a demonstration of how we are going to close a hole without surgery in the catheterization laboratory. The basic difference between catheterization laboratory and surgery is that surgery involves a cut in the chest, opening the heart, patching the hole with a pericardium or some other membrane. For that you have to stop the heart. You cannot do the operation in a beating heart. So for stopping the heart, you have to connect the heart to a heart-lung machine, and for about 1 to 2 hours you have to take control over the entire circulation through a machine. The heart is made still by giving an injection called cardioplegia. The heart doesn't move at all, and it will be cut open and the hole will be closed. The advantage of this method is that there is no cut in the chest, there is no scar. The procedure is faster. The whole procedure may be completed in about 30 minutes to 45 minutes. So here we are going to demonstrate how we are going to do that. This child is being sedated with a little bit of medicine that puts him to a deeper level of sleep so that he is not aware about the pain. A small injection through a small tube is going through the right groin, and into that we are now going to take a catheter. This catheter is as thin as a 2 millimeter tube. So this tube is now going to enter into the heart. Now we can look at this picture. So this is the catheter that has gone into the right atrium. So now what we are doing is advance this from the right atrium now through the hole into the left atrium. What you saw on the right side is the right upper chamber, and what you are now seeing is the left upper chamber. One magnification. So here you are finding that the catheter is now gone into the left side of the heart through the hole, and now we want to stabilize this catheter. So we are going to be advancing this catheter into the lungs. So the lungs blood return to the left side of the heart. So now we have reached the left side of the heart. Stiff wire. So at this point we pass a guide wire to stabilize this position. So you can keep watching in this that we are advancing a guide wire which goes into the lungs through the hole, and now I am taking out this tube that I have initially advanced. At this stage I am taking out the small tube that we have advanced. Now we are going to change it into a larger tube. In order to prevent the blood from clotting on all these tubes, we give a blood thinner which is called heparin, which acts for about few hours, 1 to 3 hours. So this is the next step, is advancing the sheath. So this sheath is a slightly larger tube. It measures about 4 to 5 millimeters. It will be the size of a small pen, and that goes through the groin vein all the way into the heart, through the hole, and enter the left atrium. So here you will observe that I am advancing the tube. This tube goes all the way through the right atrium, into the left atrium, and into the lungs blood vessel. So once this step is completed, we take out the tube and the guide wire. So as you observe, we are now taking out the guide wire, just leaving behind only the tube. So currently what is there is a tube that goes from the groin vein all the way into the right side upper chamber called the right atrium, crossing through the hole into the left side. This is the device. This device is made up of a material called nitinol. Nitinol is an alloy of nickel and titanium. It has got a particular property that the device will get into a correct memory. Now keep watching it. It looks circular if you see it from the side, but when I open it, there are two discs. There is one disc on the left side and one disc on the right side. I'm going to open it further. So there is one disc on the left side and one on the right side. So the purpose of this intervention is to put the left disc on the left side, right disc on the right side, so that the central waist now closes the hole. So imagine that I have the hole in my heart like this. The device will sit like this. So now the hole is closed from the right side and the hole is closed from the left side. What we need to do is position this device across this hole in the correct manner. So this is now connected to this cable. Now if you watch it, I can pull this device into this small tube, and the whole device now is inside this small tube. I have to go and open out the left atrial disc on the left atrium, pull it to the hole like this, and then deploy the right side, which is the right atrium. So the device has got two discs. All the two discs are now slenderized. It's in a tiny tube. So I position it in such a way that the left-sided disc is in the left side of the heart. I slowly withdraw. I keep on withdrawing in order to get the left side disc on the left side. Now I am going to check it on the echocardiogram, fluorostore, and run it back. So this is the previous position. I have now taken it into the sheath. I have turned it towards the direction of the hole, and now again I am opening out the left atrial disc on the left side of the chest. Once this is done, the next step will be, hands out. The next step will be, I am going to open out the right-sided disc. This is the right-sided disc. This right-sided disc goes and clasps the left-sided disc. The device seems to be stable without any movement. So the next step will be releasing the device. So here I am unscrewing, and while I am unscrewing, the device is released from my tube. So now the whole tube comes out. What is remaining there is the device with two discs, one on the left side, one on the right side. What you see on the right side of the screen is the left atrium, and what you see on the left side of the screen is the right atrium, the two discs clasping the hole. And now tissues will grow into both these discs and completely seal it. At this point, come to AP view, I will show you an echocardiography which will demonstrate the four chambers of the heart. I'll just orient to you. This is the right-sided upper chamber and the right-sided lower chamber. This is called right atrium and this is called right ventricle. This is the left-sided upper chamber and left-sided lower chamber, which is called left atrium and left ventricle. This boy was born with a large hole in this location, so that the blood from the left atrium was continuously going into the right atrium, causing the enlargement of these two chambers. Now what we have done is, we have closed the hole. Over the next 6 months, what will happen is, this enlargement will slowly become normal.
Once the surgery is completed, doctors usually clap in celebration of a success procedure. The non-invasive or non-surgical procedure has been said to be beneficial to children and adults, as the results are remarkable and leaves one with almost no scars.
He'll be made to wake up by withdrawal of the sedative medications. In about 3 to 4 hours, he'll be eating his food, and by tomorrow morning, he'll be back home. He'll be given a small amount of blood thinner called aspirin for the next 6 months. The advantage of this procedure is that we have avoided open heart surgery. Open heart surgery is not just a scar in the chest. It means stopping the heart for about 90 minutes and allowing the heart to be circulated through an extracorporeal machine. That means outside the body you are now controlling the whole of the circulation through a machine. Usually it is very safe. But very rare number of patients who go through this heart-lung machine and who go through this open heart surgery may end up in strokes or kidney damage or lung damage, and they may spend longer periods. The advantage of this procedure is that the body is maintaining its own circulation throughout the procedure.
You can imagine the amount of benefit that these children have had. You can imagine the amount of money you have saved, because the cost of an open heart compared to the cost of this is tremendous. You can also imagine the amount of morbidity you have saved. Who will know that this child ever had a heart problem? If it is done when you are a baby and your mother doesn't talk, nobody will know. There will be no scar to tell it off. And so it is one of the most cosmetic procedures that you'd like to have. Even as an adult, we've done adults here, and it is satisfying. The fact that I can live without a lot of tubes once I'm awake and I'm still seeing tubes around me, and the fact that I can go home the next day is one of the marvelous developments in the field of pediatric cardiology that we are also practicing in this region.
Of course, the procedure cannot be done by one person. It actually takes a village, as Africans say, to produce such experienced professionals.
It needs the help of a lot of people. Dr. Chitira is the head of the nursing team. There's a lot of effort that goes from nurses. Ronald is the anesthesia technician, radiographer, and we have Dr. Mark Akashi, who is the anesthetist, and a host of people who take part in this procedure in monitoring the patient, in preparing the patient, and in ensuring that after the operation, the patient remains stable till he is discharged the next day morning.
Non-invasive procedures have brought hope and healing to the youngest hearts as they can go back to their normal lives quite faster. Building Waliabula KT News.